This lecture will be going over Chapter 3, Fluid, Electrolytes, Acid-Base Balance, and Intravenous Therapy in the MedSurg textbook. More than half of the human's body's weight is in water. The older adult and the very young are more likely to experience severe consequences with even minor changes in their fluid balance. We will remember that fatty tissue does not contain as much water as other tissues. Thus, the greater amount of fat you have in your body, the less percentage of body water as well. Water in the body has four main functions. It is a vehicle for the transportation of substances to and from cells. It aids in heat regulation by providing perspiration, which evaporates and then cools the body. It assists in the maintenance of hydrogen balance in the body, and it serves as a medium for the enzymatic action of digestion. Body fluids are continuously in motion, moving in and out of the blood and lymph vessels, through the spaces of the surrounding cells, and through the bodies of the cells themselves. Fluid within a cell is considered to be in one compartment, the intracellular compartment, and fluid outside of the cell is in the extracellular compartment. Excretion of the body's fluids is achieved mainly through the kidney, with some loss in stool. Control of fluid balance is managed by the following. Osmoreceptors. These are found in the hypothalamus. They sense the internal environment, which is the ratio of fluid to solutes, and promote the intake of fluid or the thirst mechanism when needed. Baroreceptors in the carotid sinus and aortic arch will detect pressure changes that indicate an increase or decrease in blood volume, and can then stimulate the sympathetic or parasympathetic nervous system to return the pressure to normal. Antidiuretic hormone, or ADH, is released by the posterior pituitary. It controls how much fluid leaves the body in the urine and causes reabsorption of water from the kidney tubules. Aldosterone regulates the reabsorption of water and sodium ions from the kidney tubules. Brain natriuretic peptide, or B-type natriuretic peptide, this is BNP, and atrial natriuretic peptide, or ANP, both promote the loss of water and sodium ions from the kidney and will cause vasodilation. Pain, nausea, and stress can also cause the release of ADH by the pituitary, but the primary triggers for release are decreased blood pressure or increased concentration of the blood. The primary triggers for release of ADH are decreased pressure or increased concentration of the blood. The renin-angiotensin-aldosterone system will regulate the release of aldosterone. Renin is released when there is decreased blood flow to the kidney. ANP will help protect the body from fluid overload by increasing sodium excretion. And of course, where sodium goes, water will follow. If the ventricles are stretched with volume, BNP is then released because it is a stronger diuretic than ANP. To be normally distributed within the body, water and the substances suspended or dissolved in water need to move from compartment to compartment. Buddy. As blood flows through the capillaries, fluid and solutes can move into the interstitial spaces, where the cells of the body can then exchange nutrients and waste. Assessment of fluid balance is primarily achieved through monitoring of the intravascular space and external signs of symptoms of too much or too little fluid. Labs are drawn and blood pressure can also be assessed in the vasculature. Non-electrolyte substances include protein, urea, glucose, creatinine, and bilirubin. Along with electrolytes, solutes contribute to the osmolality. This is the concentration of the solution determined by the number of solutes in it. Osmolality controls water movement and the body fluid distribution in the intracellular and extracellular compartments. Potassium maintains the osmolality of the intracellular fluid. Sodium controls the osmolality of the ECF. Diffusion is the process by which substances move across the membrane until they are evenly distributed in the available space. When the solution on one side of the membrane is more concentrated than the solution on the other side of the membrane, the particles in the more concentrated solution will travel through the membrane to the less concentrated side in an attempt to equalize the concentration of the two solutions. Diffusion is a spontaneous mixing and moving that allows the exchange of molecules, ions, cellular nutrients, wastes, and any other substances dissolved or suspended in body water. Substances will move from a high to a low concentration until the concentration on both sides of the membrane is equal. This is called movement down a concentration gradient. Glucose, oxygen, carbon dioxide, water, and other small ions and molecules move by diffusion, and this is a process of equalization. Many intracellular proteins will have a negative charge that will attract positively charged sodium and potassium ions from the ECF. These ions will then diffuse across the membrane until there is a balance of electrical charges on either side of the membrane. Osmosis is the movement of pure solvent or liquid across a membrane. Water moves by osmosis. This process takes place with a semi-permeable membrane. Fluids will move between the interstitial and intracellular compartments and between the interstitial and intravascular compartments by osmosis. When living cells are surrounded by a solution that has the same concentration of particles, the water concentration of the ICF and the ECF will be equal. This type of solution is called isotonic. If cells are surrounded by a solution with a greater concentration of solute than their cells, that solution is considered hypertonic. The water in those cells will move to the more concentrated solution, and the cells will then dehydrate and shrink. If cells are surrounded by a solution that has less solute than the cells, that solution is hypotonic. The particles within the cells will then exert osmotic pressure, drawing the water inward through the semi-permeable membrane. They will swell from the extra fluid and eventually burst. Solutions are classified as isotonic, hypertonic, or hypotonic, according to their concentration of electrolytes and other solutes. Filtration is the movement of water and solutes through a semi-permeable membrane as a result of a pushing force on one side of the membrane. This occurs in the kidney, where waste substances and excess water are eliminated. The pumping action of the heart creates a hydrostatic pressure. This is pressure exerted by fluid within the capillaries. Hydrostatic pressure causes fluid to move outward on the vessel. The lymph system also has a filtration role using the hydrostatic pressure generated from the heart. It filters bacteria from lymph, and the spleen filters the blood of old red cells. In contrast to diffusion, osmosis, and filtration, active transport requires cellular energy. This can move molecules into cells, regardless of their electrical charge or the concentrations already present. Active transport might move substances from an area of lower concentration to an area of higher concentration. Amino acids, glucose, iron, hydrogen, sodium, potassium, and calcium are all moved through the cell membrane via active transport. The sodium pump is the mechanism by which sodium and potassium are moved into or out of the cell via active transport. Healthy people can maintain fluid balance by drinking sufficient fluids and eating a balanced diet every day. The healthy kidney will balance the amount of substances entering and leaving the blood, helping to maintain normal concentration of fluid and electrolytes. Illness will affect our fluid balance in many ways. Any disease that affects circulation, such as heart failure, will ultimately affect the distribution and composition of body fluids. Perspiration can account for a fluid loss of up to 2 liters per hour in an adult. For every degree of fever on the Celsius scale, an insensible or unaware of water loss of about 10% can occur. Perspiration and water lost in respiration are also insensible losses. Any seriously ill patient is at risk for a fluid and electrolyte imbalance. A fluid imbalance will exist if there's an excess or a deficit of water in the body. It is important to remember that water follows sodium in the body through osmosis. Patients at risk for deficient fluid volume are those who are unaware or unable to take in sufficient quantities of fluid due to impaired swallowing, extreme weakness, disorientation or coma, or the unavailability of water, or those who lose excessive amounts of fluid through prolonged vomiting, diarrhea, hemorrhage, diaphoresis, excessive wound drainage, or diuretic therapy. Fluid volume deficit will result in dehydration of cells. Dehydration is treated by administering fluid orally, intravenously, or through a feeding or gastrectomy tube. Turgor, or the degree of elasticity, can be checked by gently pinching up the skin over the abdomen, forearm, sternum, forehead, clavicle, or thigh. If a fluid deficit is present, the skin might remain elevated or tented for several seconds. In infants, dehydration can be evident by sunken fontanelles. On page 35, take a look at the clinical cues in the purple box. The most accurate measure of fluid gain or loss for any age group is a weight change. We can calculate a weight gain or loss of 2.2 pounds, also known as 1 kilogram, in 24 hours would indicate a weight gain or loss of about 1 liter of fluid. You can see the signs and symptoms of dehydration and overhydration on page 35, box 3.2. Many older adults will rely on laxatives and enemas to clear their bowel. This practice can cause fluid volume deficit along with sodium and potassium losses. Fluid volume deficit contributes to constipation and orthostatic hypotension with related dizziness and falls. This can make a person more susceptible to infection. If a person has a fever, that will also add to their loss. Remember that constipation can be an early indicator of dehydration in the older adult. Provide an adequate fluid intake for those who are unable to do so for themselves. Be sure to include the patient's preferences for any liquids in their plan of care. Nausea is a feeling of discomfort or an unpleasant sensation vaguely felt in the epigastrum and abdomen. It is a symptom of illness and is often accompanied by vomiting. Pain can trigger the nausea-vomiting mechanism. Nausea and vomiting may occur from gastrointestinal irritation due to foods, viruses, radiation of the mucosa, or some drugs or other chemicals. Certain types of anesthetics can trigger nausea, as well as pregnancy. If vomiting occurs, the vomitus should be observed for odor, color, contents, and amount. Note and record the vomiting patterns, as well as conditions that trigger vomiting, the quality of nausea as described by the patient, and these all can be helpful when planning treatment. Medical treatment for nausea consists of administering an antiemetic drug. Antihistamines, sedatives, and hypnotics, anticholinergics, phenothiazines, and other drugs can be used to control nausea and vomiting. Have the patient lie down and turn their head to one side, or you can have them sit and lower their head between their legs so that their vomit is not aspirated into the respiratory tract. Use a cool, damp washcloth to wipe the patient's face and the back of their neck. Any fluid loss through the GI tract, such as vomiting or diarrhea, can result in hypokalemia and hyponatremia. Diarrhea is defined as the rapid movement of fecal matter through the intestine. Frequent watery bowel movements, abdominal cramping, and general weakness will characterize diarrhea. It is the consistency rather than the number of stools per day that is the hallmark of diarrhea. During diarrhea, patients absorb nutrients poorly and they lose water and electrolytes. These electrolytic substances, especially potassium, are lost in large amounts by patients with diarrhea. Most diarrhea is related to local irritation of the intestinal mucosa, especially irritation caused by infectious agents such as Salmonella, Clostridium difficile, and E. coli. Gluten intolerance is recognized to cause GI disorders, and sensitivity to gluten would include alternate bouts of diarrhea and constipation in its list of symptoms. To rest the intestines and stomach of a patient with acute diarrhea, you should limit the intake of foods. Once oral feedings are allowed, begin clear liquids, and then progress to bland liquids, then solid foods of increased calories, as well as high protein and high carbohydrate content. They should be educated to avoid iced fluids, carbonated drinks, whole milk, roughage, raw fruits, and highly seasoned foods. Medications prescribed for diarrhea will depend on the cause of the disorder and the length of time the condition has been present. Diarrhea caused by infections can be treated with drugs that are specific for the causative organism. Depending on the organism responsible, it is sometimes advisable to allow those toxins to be eliminated naturally from the body. Therefore, the drugs may not be given initially. Nursing measures for diarrhea aim to provide physical and mental rest, prevent unnecessary loss of water and nutrients, protect the rectal mucosa, and eventually replace lost fluids. The emotional stress will only serve to make the condition worse. An excessive amount of body water usually occurs first in the extracellular compartment because this is where water enters and leaves the body. When people become ill, they might receive more water than they excrete. This can happen if IV fluid is given too quickly or if patients are persuaded to drink more fluids than they can eliminate. This can result in water intoxication. Impaired elimination, such as occurs with renal failure, is a major cause of fluid volume excess. An objective measure of water excess and circulatory overload is the hematocrit level. The hematocrit measures the percentage of red blood cells in a volume of whole blood. When fluid volume excess occurs, hypervolemia may also occur. Hypervolemia can elevate blood pressure. Urine concentration will provide another clue as to the fluid status. When looking at specific gravity, we will remember that the average range is 1.010 to 1.025. Edema is associated with the retention of water, sodium, and chloride, and is defined as an accumulation of freely moving interstitial fluid. Look for puffy eyelids and swollen hands. Edema can also occur in body cavities, as in the peritoneal cavity, ascites, and the cranial cavity. The accumulation of body fluids can affect almost all tissue spaces, and this is termed generalized edema. Alternatively, fluid accumulation can only affect a limited area, and this would be called localized edema. Edema can become life-threatening when the accumulated fluids overload the circulatory system, as occurs in congestive heart failure, or when fluids accumulate in the lungs, as in pulmonary edema. 4 general causes of edema are an increase in capillary hydrostatic pressure, a loss of plasma proteins, an obstruction of lymphatic circulation, or an increase in capillary permeability. When an inflammatory response or infection occurs, histamine and other chemical mediators are released from cells involved in the tissue injury. These chemicals cause an increased capillary permeability, and more fluid will then leak into the interstitial spaces. Proteins will leak into the interstitial spaces as well, decreasing the osmotic pressure in the capillaries. Protein in the interstitial spaces will hold fluid there rather than moving it back into the capillary. When fluid shifts from the vascular space to the interstitial space, dehydration and hypovolemia can occur. When fluid shifts from the vascular space to the interstitial space, tissue edema could be present, but the actual circulating volume could be deficient. This shift of fluid is called third spacing. This can occur with extensive trauma, burns, peritonitis, intestinal obstruction, nephrosis, sepsis, or cirrhosis of the liver, in which there is an increase in capillary hydrostatic pressure or increased capillary membrane permeability. Localized edema is usually non-pitting, does not come and go, and is characterized by tight, shiny skin that is stretched over a hard and red area. Dependent edema can be noted in the feet, ankles, and lower legs, or in the sacral region of patients confined to a bed or chair. Dependent edema is an effect of gravity and therefore can be somewhat relieved by elevating the body part about 18 inches or above heart level when possible, as well as repositioning the patient frequently. To check for pitting edema, press your thumb into the patient's skin at a bony prominence, such as the tibia or malleolus, and hold it there for 5 seconds. If a depression or pit remains for a while after you release the pressure, the patient has pitting edema. On page 40, you can see the scale used for rating pitting edema. Treatment of a fluid imbalance involves correcting the underlying cause and assisting the body to rebalance fluid content. A diuretic is a drug that prompts the kidneys to increase the excretion of fluid. Bed rest might be ordered to facilitate fluid excretion because the kidneys function best when the body is supine. A low-sodium diet is initiated, and intake and output recording needs to be initiated as well. It is important to teach your patients with a fluid deficit and their family how to measure fluid intake and output and how to keep a log of these amounts at home. If an older adult has been vomiting considerably for several hours or has had constant diarrhea without fluid intake, they need to have a visit to the emergency department so that they can get IV fluids and prevent serious dehydration. A patient with fluid excess needs to be weighed daily and a chart kept. Some molecules, when placed into a solution, undergo a separation of their atoms into electrically charged ions. These molecules are then called electrolytes because their atomic particles can conduct an electrical current. The molecules of electrolytes break up into atomic particles that are either negatively charged, known as anions, or positively charged, known as cations. Because electrolytes are electrically charged, they are chemically active. To determine whether or not there is an electrolyte imbalance, you need to know the normal range for each electrolyte. Hyponatremia is a deficit of sodium in the blood where the sodium is less than 135 milliequivalents per liter. This is the most common electrolyte imbalance. The average intake of sodium is 4 to 5 grams per day. The consequence of hyponatremia is impaired nerve conduction. Hypernatremia occurs when the sodium level rises above 145 milliequivalents per liter. Water loss from fever, respiratory infection, or watery diarrhea can cause hypernatremia, but usually impaired thirst or restricted access to water are the primary causes. Sodium intake needs to be restricted for these patients with hypernatremia. On page 42 in table 3.3, you can see all the normal ranges and functions for the major electrolytes. That definitely needs to be studied for the exam. Table 3.4 on that same page and continuing on to page 43 and 44 will also list the electrolyte imbalances for you with the signs and symptoms and nursing interventions. Definitely important to pay attention to hyponatremia, hypokalemia, and hypocalcemia for exam purposes. On table 44, also take note of some foods high in sodium in the red nutrition considerations box. Notice that ketchup, cheese, dried fruits, and tomato or vegetable juice are all very high in sodium. Hypokalemia occurs when the potassium level falls below 3.5 milliequivalents per liter. This has a variety of causes and can cause serious problems. It's important to teach patients taking diuretics that are not potassium sparing to increase their potassium in the diet. Take potassium supplements as prescribed and watch out for any symptoms of hypokalemia. Severe hypokalemia, less than 2.5 milliequivalents per liter, can cause cardiac arrest. Take a look at the safety alert on page 45 in the red box regarding intravenous potassium. Adequate renal function needs to be present before IV potassium can be administered. IV potassium must always be diluted before administration and is absolutely never given as a push injection. Hyperkalemia occurs when the serum potassium level rises above 5.0 milliequivalents per liter. The most common reason for increased potassium levels is decreased excretion by the kidneys due to either renal insufficiency or drug effects. Hyperkalemia can cause life-threatening cardiac dysrhythmias. Hypocalcemia occurs when the calcium level drops below 8.4 milligrams per deciliter. Hypocalcemia results from disorders in which there is a shift of calcium into the bone. Conditions that cause alkalosis can also cause hypocalcemia. Calcium ions are needed for a variety of metabolic processes and enzyme reactions, including blood clotting. Calcium deficit will upset the stability of nerve membranes. This causes abnormalities in nerve conduction and muscle contractions. A carpopedal spasm, also known as Trousseau's signs, hyperactive reflexes, Chvostek's sign, and tetany may occur. Laryngospasm can also occur if the deficit is severe. Check for Trousseau and Chvostek signs when calcium or magnesium deficit is a possibility. Test deep tendon reflexes by tapping a partially stretched muscle tendon with a percussion hammer. The extent of the reflex is then scored from 0 to 4+, with 0 representing no response, 2+ a normal response, and 4+ a hyperactive response. Hypercalcemia occurs when the serum calcium level is above 10.6 milligrams per deciliter. This can occur during periods of lengthy immobilization, when calcium is mobilized from the bone, or when an excess of calcium or vitamin D has been taken into the body. Hypomagnesemia occurs when the serum level drops below 1.3 milliequivalents per liter. This is typically present when hypokalemia and hypocalcemia occur. Magnesium is important in DNA and protein synthesis and in many enzymatic reactions. Magnesium imbalances are rare, but they can be caused by a variety of factors. Hypermagnesemia is present when the serum level is above 2.1 milliequivalents per liter. This can occur in the presence of renal failure or from the overuse of magnesium-containing antacids and cathartics. Hypermagnesemia is rare. Because of electroneutrality, imbalances of chloride, phosphate, and bicarbonate will accompany cation imbalances. Hypochloremia is a chloride level greater than 95 milliequivalents per liter. This is associated with hyponatremia. Hyperchloremia is a chloride level greater than 103 milliequivalents per deciliter. This would coincide with hypernatremia in a form of metabolic acidosis. Hypophosphatemia will occur when the phosphate level falls below 3.0 milligrams per deciliter. Hypophosphatemia can result from the use of aluminum-containing antacids that bind phosphate, vitamin D deficiency, or hyperparathyroidism. Hyperphosphatemia is a level greater than 4.5 milligrams per deciliter, and it commonly occurs with renal failure. The difference between the primary measured cations and the primary measured anions is called an anion gap. The cations measured include sodium and potassium, and the anions include chloride and bicarbonate. The normal value for an anion gap is 3 to 11 milliequivalents per liter. This can be used to help identify acid-base imbalances. A high anion gap can indicate an acidotic state. It is crucial to maintain acid-base balance because cell enzymes function within a very narrow pH range. This is 7.35 to 7.45. Enzymes in the kidney will promote the formation of hydrogen ions, which are excreted in the urine while the bicarbonate ions are returned to the blood. Acids can be removed in the kidney by combining them with ammonia and other basic chemicals. Urine pH can vary from 4.5 to 8.0 as kidney compensation occurs. Most of the body's metabolic activities produce CO2. This moves from the tissues in the blood where it will combine with water to form carbonic acid. If the ratio is not maintained, acid-base balance can be upset. There are three mechanisms that control or rebalance pH. Buffer pairs. These are groups of chemicals that absorb excess acids or excess bases circulating in the blood that respond to pH changes quickly. The bicarbonate carbonic acid buffer system is responsible for more than half of the buffering. Three other buffer systems in the body include the phosphate, hemoglobin, and protein systems. The respiratory system alters breathing rate and depth. Because carbon dioxide dissolves in the blood and combines with water to form carbonic acid, retaining or blowing off carbon dioxide will help retain or eliminate acids from the body. The kidneys change the excretion rate of acids and the production and absorption of bicarbonate ion. The kidneys are slow to compensate, but they are the most effective compensating mechanism. A buffer is any substance that increases the amount of acid or alkali in the solution to produce a unit change in pH. In a respiratory imbalance, the lungs will retain or blow off excess carbon dioxide, or just carbon dioxide. In hypoventilation, the lungs do not eliminate carbon dioxide, and carbon dioxide will remain in the body, unite with water, and then form carbonic acid. The opposite of this is hyperventilation, in which too much carbon dioxide is being blown off. The kidneys are the normal principal organs of control in maintaining a normal pH during metabolic activities, because they will either reabsorb or excrete bicarbonate. In the presence of respiratory acidosis, the kidneys will retain and manufacture more bicarbonate than normal, so that it's available to neutralize the excess acid. However, this is a slow process. It can take a few hours to several days to be accomplished. Many complex chemical activities are involved in maintaining an internal environment that must be slightly alkaline for normal body function. Imbalances can be acute or chronic. An initial change in carbon dioxide is nearly always the result of a respiratory disorder. Metabolic disorders show an initial change in bicarbonate ions. Three control mechanisms will continuously work together to maintain the acid-base balance: the respiratory system, the kidneys, and the bicarbonate buffer system. Blood gas studies are a valuable indicator of a patient's progress towards recovery or their lack thereof it. The result of analyses of arterial blood gases are reported as follows. PaO2. This is the partial pressure exerted by oxygen in the arterial blood. The normal value is 80 to 100, and it indicates the amount of oxygen carried in the blood. PaCO2. This is the partial pressure of carbon dioxide in the arterial blood. The normal value is 35 to 45, and it indicates the amount of carbon dioxide in the blood. pH. This is an expression of the extent to which the blood is alkaline or acid. The normal value is 7.35 to 7.45. SaO2, also abbreviated as oxygen saturation. This is the percentage of available hemoglobin that is saturated with oxygen, that is, the ratio to the amount of oxygen combined with hemoglobin to the total amount of oxygen that the hemoglobin can carry. A normal value is typically 94 to 100%. HCO3. This is the level of plasma bicarbonate, an indicator of the metabolic acid-base status, and a normal value is 22 to 26 milliequivalents per liter. Base excess or deficit. This indicates the amount of blood buffer present. Alkalosis is present when this value is abnormally high. Abnormally low values will indicate acidosis. Alkalosis is measured in positive or negative values. An increase in carbon dioxide levels will occur in a variety of disorders, and it can be seen in the following conditions. Acute problems like airway obstruction, pneumonia, asthma, chest injuries, or pulmonary edema. COPD, such as emphysema, and with opiate use that depresses the respiratory rate. A patient with COPD is most likely to develop acute acidosis when an infection of the respiratory tract further impairs breathing capacity and the removal of carbon dioxide. Signs and symptoms of respiratory acidosis include complaints of increasing difficulty with breathing, a history of respiratory obstruction, dyspnea, weakness, dizziness, restlessness, sleepiness, and change in mental alertness. The treatment for respiratory acidosis is establishment or maintenance of an airway, use of non-invasive positive pressure ventilation, or the insertion of an endotracheal tube might be necessary. Oxygen administration may be needed, and the assistance of a mechanical ventilator might be required. Care should be taken when administering certain drugs that depress the respiratory center, including narcotics, hypnotics, and tranquilizers. The patient needs to be watched closely for any respiratory or cardiac arrest. An excessive loss of bicarbonate ions or an increased production or retention of hydrogen ions will lead to metabolic acidosis. The main cause of metabolic acidosis includes excessive loss of bicarbonate ions from diarrhea, renal failure, diabetic ketoacidosis, hyperkalemia, and sepsis. The symptoms of metabolic acidosis include weakness, lethargy, headache, and confusion. If the acidosis is not relieved, these symptoms will progress to stupor, unconsciousness, coma, and death. The breath of the patient with DKA may have a fruity odor from the ketone bodies. When compensatory mechanisms are not working to control metabolic acidosis, the patient might have deep, rapid breathing, known as Kussmaul's respirations, and they may also secrete urine with a very low pH. Treatment of metabolic acidosis is aimed at the underlying cause. Immediate treatment of severe metabolic acidosis will require treating the underlying cause and administration of IV bicarbonate. Alkalosis is less common than acidosis. Hyperventilation, which is a rapid respiratory rate, results in respiratory alkalosis. Hyperventilation is usually caused by anxiety, high fever, or an overdose of aspirin. Head injuries can also lead to hyperventilation. Symptoms of respiratory alkalosis include deep, rapid breathing, tingling of the fingers, pallor around the mouth, dizziness, and spasms of the muscles of the hands. Treatment for hyperventilation will address the underlying disorder. Sedatives can be given to calm the patient. To aid in the retention of carbon dioxide, the patient may be instructed to hold their breath or to breathe into a paper sac, and then rebreathe the carbon dioxide just exhaled. Metabolic alkalosis will follow a loss of hydrochloric acid from the stomach. These causes include vomiting, extensive GI suction, hypokalemia, and excessive use of antacids with bicarbonate. Hypokalemia causes metabolic acidosis because the kidney retains potassium while excreting hydrogen. Symptoms of metabolic acidosis include neurologic signs such as irritability, disorientation, lethargy, muscle twitching, tingling, and numbness of the fingers and convulsions, and respiratory manifestations such as slow, shallow respirations, decreased chest movements, and cyanosis. In addition, there may be symptoms of potassium and calcium depletion. If alkalosis progresses, tetany will occur, with resulting seizures and coma. Treatment is directed at correcting the underlying cause and attempting to restore the body fluids to a less alkaline state. Emergency measures would include the administration of an acidifying solution, such as ammonium chloride. For the home care patient, teach about the requirements for fluid intake or restriction. Obtain feedback to be certain that the patient understands your instructions. Collaborate with the patient on the plan of care to obtain patient compliance. When acid-base balance occurs, acid-base imbalance occurs, control of the underlying disorder is a priority. Administering fluids through the veins is the most common means by which water, electrolytes, nutrients, and some drugs might be given when an oral uptake is not possible or needs to be supplemented. Intravenous therapy is often used when a fluid deficit is present or when there is an electrolyte imbalance. Intravenous fluids can also be used to help reestablish acid-base balance. Isotonic is a solution with the same osmotic pressure as ICF. Hypotonic, a solution with lower osmotic pressure than that of body fluids. Note that sterile distilled water is hypotonic and should never be added to an IV solution. Hypertonic, a solution with a higher osmotic pressure than that of body fluids. An example of an isotonic solution is 0.9% normal saline. Whole blood is rarely given. Even with hemorrhage, blood components are usually given for replacement. Packed cells can be administered to patients with anemia or some other blood disorder. Plasma is stored in the frozen state, so the order will be for fresh frozen plasma, or FFP. Plasma is given primarily to replace coagulation factors, but can also be used to increase blood volume, such as in shock, and to provide protein. Protein can also be supplemented by the use of human albumin. In the treatment of shock, we use plasma expanders to increase the volume of plasma. Some examples of plasma expanders include low molecular weight dextran, albumin, Hespan, and plasminate. Blood disorders and other blood product administration are also going to be explained more in Chapter 16. Responsibility for the safe and effective administration of IV fluids rests with every member of the nursing staff. Maintaining sterility is paramount. IV access devices will provide a direct route to the bloodstream for organisms whenever aseptic technique is compromised. The 4 goals of nursing care for a patient receiving an IV infusion are 1. Prevent infection. 2. Minimize physical injury to the veins and surrounding tissues. 3. Administer the correct fluid at the prescribed time and at a safe rate of flow. 4. Observe the patient's reaction to the fluid and medications being administered. All equipment and fluids used for IV therapy need to be sterile and safe for administration. Before any plastic bag or bottle of solution can be added to an IV set, it needs to be checked for any leaks or possible contamination. Due to the danger of incompatibility, it is also essential to check each drug and the solution to be certain that they can be mixed together. Always wash your hands just before handling IV fluids and equipment. The port on the IV tubing into which the administration set of a piggyback medication is to be attached needs to be carefully and thoroughly wiped with a fresh alcohol swab, scrubbing thoroughly for 15 seconds before the tubing is attached to the IV port. If a protective alcohol cap is in use, follow your manufacturer's recommendations for sanitizing. There should be a clear, occlusive, airtight dressing over the IV insertion site. Dressing should be changed according to agency protocol, but current guidelines will recommend changing the dressings every 5 to 7 days. If a dressing becomes loose, soiled, or contaminated, it should be removed and a new dressing applied. Be sure to label your tubing and dressings with the date. When an IV infusion is discontinued, the tubing is clamped, all tape is removed, and the needle or catheter is gently but quickly withdrawn using standard precautions. Always check to be sure that the catheter has been completely removed and that the tip is intact. On page 54 in box 3.4, you can see the 6 rights applied to IV therapy. Be sure that you have the right solution, the right dose, the right route, the right time, the right patient, and the right documentation. Very similar to our medication 6 rights. because IV medications or IV therapy, they are all considered medications. Even normal saline is a medication. The rate of flow is an important factor in safe and effective IV therapy. Intravenous setup should be checked once every hour to be sure that the fluid is running correctly and that there are no problems. Intravenous pumps, although not infallible, will keep IV fluids flowing at the desired rate and act as a safeguard should any problem arise. Even when an IV pump is used, you need to check that it is delivering the solution accurately as prescribed. Principles that affect the rate of flow for IV infusions that are not given on a pump include the following. The higher the container is placed above the level of the patient's heart, the faster the rate of flow will go because gravity will affect that flow. The higher you hang it, the faster it runs. The fuller the container, the faster the flow. The more viscous or thick the fluid is, the slower it will flow. That's why packed red slows flow about 5% more slowly than dextrose in water. The larger the diameter of the needle and tubing, the faster the flow. That's why when you're doing a blood administration, it is preferable to have a 20 gauge needle or larger for any type of blood product administration. The higher the pressure within the vein, the slower the flow. Fluid will pass through a straight tube faster than one that is coiled or hanging below the level of the cannula. If the IV infusion slows down and has not been checked or readjusted for some time, you should make no attempt to catch up by speeding up the rate of flow beyond what has been ordered. This can lead to circulatory overload or a volume excess that can produce pulmonary edema in susceptible patients. IV infusion pumps will track the amount of fluid infused through them. At the end of the shift, the count is zeroed and the volume infused is recorded within the medical record. Flushing the catheter or line will prevent any contact or reactions between the fluid that was last infused and any incompatible drugs. Flushing the catheter or line will also maintain patency of the lumen. Either normal saline alone or normal saline followed with a heparin solution should be used. Before using an as-needed or PRN saline lock, be sure to flush the catheter according to your agency policy to determine patency of the lumen, as well as flush out any heparinized solution. If you feel any resistance when flushing, stop immediately. Depending on the length of the catheter in place, you should use about 3 to 10 mLs of normal saline. PRN locks and catheters should be flushed immediately after use or whenever an IV piggyback medication infusion is completed. Delay in disconnecting the intermittent infusion administration set and flushing the lock could allow blow to backflow into the catheter lumen because the infusion pressure drops lower than the venous pressure when the infusion is complete. In such a case, a clot can form, occluding the lumen. The catheter can also clot off if the infusion pump is stopped without disconnecting the IV tubing and flushing the PRN lock. Be aware that when an intermittent infusion should be completed, and at the appropriate time, you should be back at the bedside prepared to remove that piggyback infusion setup and flush your PRN lock. IV pumps will alarm when they're complete so that the IV site can be appropriately managed. If a gauze dressing is in place, provide site care every 24 to 48 hours per agency protocol. Transparent dressings on a central line device would require site care every 5 to 7 days. Every central line dressing should be examined once every shift, and the dressing should be changed whenever soiled. Drawing blood from a central line should be performed using strict aseptic technique. Blood should be withdrawn for discard, and then the sample should be obtained. Follow your agency protocols for flushing after the blood draw, as well as timing of cap changes. Many patients with fluid and electrolyte imbalances are nutritionally depleted. Partial parenteral nutrition, or PPN, is given when a patient cannot maintain an adequate nutritional status with oral intake. PPN is given through a large peripheral vein in the arm. If sufficient nutrition cannot be delivered by oral intake and PPN or by enteral feedings, TPN is then begun. Nursing management. First, assess the patient for the risk of fluid, electrolyte, or acid-base imbalance. Then assess them for actual signs and symptoms of the fluid, electrolyte, and acid-base imbalances. Be sure to question your patient about any subjective signs and symptoms. The goal to restore the patient's fluid, electrolyte, or acid, the goal is to restore the patient's fluid, electrolyte, or acid-base balance. Be sure to write out individual expected outcomes. When patients are unable to take in sufficient fluids on their own, you should work with the healthcare provider to provide adequate fluid and electrolytes. If patients can swallow and retain fluid, assist them in frequently taking in small amounts of fluid. In addition to water, offer the patient fruit juices, bouillon, ice pops, soft drinks, or gelatin. A patient with fluid volume excess might have an order for fluid restriction. This means that the patient can only take in a certain amount of fluid over a 24-hour period. Work out a schedule of fluid intake so that liquids can be spaced evenly and the patient doesn't receive all of their allotted liquids at the same time. Diuretics can be prescribed, particularly if there is a potential for congestive heart failure or pulmonary edema. For patients at such risk, daily weights and electrolyte status need to be monitored along with strict intake and output. Skin care is particularly important in preventing a breakdown over an edematous area. The stretched skin is extremely fragile, has a decreased blood supply, and is no longer flexible. Keep bed linens dry and smooth, and turn the patient frequently to relieve any pressure over bony prominences. Be very gentle when repositioning and turning the patient. To avoid friction on the skin, you can use a turning sheet. Any break in edematous skin can quickly form a pressure ulcer. Evaluation. Every 24 hours, you should perform evaluations to determine whether nursing interventions are assisting the patient to meet those expected outcomes. When a specific outcome is met, you should discontinue that portion of the plan. Nurses in long-term care facilities deal every day with the problems of delicate fluid balance in older adult patients. This is especially important that the long-term care and home care nurse be vigilant for signs of hypokalemia. Hypokalemia will alter the way digitalis is metabolized in the body and can predispose a patient to digitalis toxicity. Signs of digitalis toxicity are fatigue, anorexia, headache, blurred vision, yellow-green halos around the eyes, nausea, diarrhea, and cardiac dysrhythmias. Clear instructions must be given to the patient and the family regarding IV therapy for home care use.